Incision and removal of foreign body, subcutaneous tissues, simple. Complicated. Physician makes a simple incision in the skin overlying the foreign body. The foreign body is removed using hemostats or forceps. The skin may be sutured or allowed to heal secondarily. Report 10121 if the procedure is more complicated, requiring dissection of underlying tissues. Example 10120. Location, left leg. Local anesthesia, bupivacaine. Foreign body, metal hook. Incision, 15 size scalpel blade. Materials used, forceps. Dissection of underlying tissues, no. Suture, no. Removal of foreign body in muscle, or tendon sheath, simple. Deep or complicated. The physician incises the skin and dissects to the muscle or sheath. The foreign body is isolated by palpation or radiographic imagery, separately reported, and removed. The incision may be closed if clean or packed if contaminated by the object. A slit lamp is a microscope with a bright light used during an eye exam. Removal of foreign body, external eye, corneal, without slit lamp. Corneal, with slit lamp. The physician may remove a superficial foreign body or mineral deposit from the cornea with the side of the beveled edge of a needle. An incision may be required to remove an embedded foreign body. If so, the physician may cut a V-shaped incision to access the defect through a flap, or a straight incision may be made. The incision does not penetrate the cornea. Generally, a slit lamp is used with any embedded foreign body. After the removal, the physician may apply a broad-spectrum antibiotic and a moderate pressure patch over the closed lid for 24 to 48 hours. Removal of embedded foreign body, eyelid. The physician administers local anesthetic and the patient's face and eyelid are draped and prepped for surgery. The physician locates the foreign body through palpation. An incision is made through the anterior surface if the foreign body is principally on the anterior of the lid is averted if the foreign body is near the posterior surface. An attempt is made to conceal the incision line in the crease of the upper lid, or through a subciliary incision, when possible. The foreign body is removed and the wound is irrigated. The wound is repaired with layered sutures. Removal of foreign body, external eye, conjunctival superficial. Conjunctival embedded, includes concretions, subconjunctival or scleral non-perforating. The physician picks the foreign body or mineral deposit from the conjunctival with the side of the beveled edge of a needle. A small incision may be required to remove an embedded foreign body. In this case, the physician may cut a V-shaped incision to access the defect through a flap, or a straight incision may be made. The incision may penetrate the conjunctiva, but it does not penetrate the sclera. Generally, a slit lamp is used when removing any embedded foreign body. After the removal, the physician may apply a broad-spectrum antibiotic and a moderate pressure patch over the closed lid for 24 to 48 hours. Removal of foreign body, intraocular, from anterior chamber of eye or lens. The physician removes a foreign body, intraocular, from the anterior chamber of the eye or lens. The physician makes a small incision in the connective tissue between the cornea and the sclera, the limbus, and retrieves the foreign body through the opening with intraocular forceps or another small instrument. Generally, foreign bodies that pierce the lens are self-sealing and removal is not attempted. The incision is sutured. The physician applies an antibiotic ointment. Sometimes a pressure patch is placed on the eye for 24 to 48 hours. Removal of foreign body, intraocular, from posterior segment, magnetic extraction, anterior or posterior route. Diagnostic tests locate the foreign body before surgery is attempted. The physician will use an electromagnetic or magnetic probe to retrieve a metallic foreign body from the area behind the lens, the posterior segment. In the anterior route, the physician first dilates the patient's pupil. In a series of moves aligning the magnet to the metallic foreign body, the physician draws the foreign body to the front of the eye and around the lens into the anterior chamber. The physician makes an incision in the connective tissue between the cornea and the sclera, the limbus, and retrieves the foreign body. In the posterior route, the physician makes a small incision in the conjunctiva over the site of the foreign body. A magnet is applied and the foreign body removed. The incision from either is repaired, and an injection may be required to re-establish proper fluid levels in the anterior and/or posterior chamber of the eye. A broad-spectrum antibiotic or a pressure patch may be applied. Among the tools common to this procedure are Gruning's, Hobbs, or Hirschberg's magnets. Removal of foreign body, intraocular, from posterior segment, non-magnetic extraction. Diagnostic tests locate the foreign body before surgery is attempted. The physician will use intraocular forceps to retrieve the non-metallic foreign body from the area behind the lens, the posterior segment. The physician makes an incision through the conjunctiva overlying the site of the foreign body. The foreign body is retrieved with intraocular forceps. Non-metallic foreign bodies in the vitreous or retina may be removed through a pars plana approach. Either incision is repaired with a layered closure, and an injection may be required to re-establish proper fluid levels in the anterior or posterior chambers of eye. A broad-spectrum antibiotic or a pressure patch may be applied. Removal of foreign body or dacrylith, lacrimal passages. The lacrimal system serves to keep the conjunctiva and cornea moist through the production, distribution, and elimination of tears. Ducts distribute the tears to the eye and nose. The physician administers a local anesthetic along the medial canthal tendon. An incision is made midway between the bride of the nose and the medial canthal tendon. The dissection is carried down to the foreign body or lacrimal stone. It is removed, and the wound is repaired with layered sutures. Removal foreign body from external auditory canal, without general anesthesia. With general anesthesia. Under direct visualization, the physician or technician removes a foreign body from the external auditory canal using delicate forceps, a cerumen spoon, or suction. In the case of a live insect, oil is dropped into the ear to immobilize it before it is removed. If a child or an adult cannot tolerate the procedure while awake, it is performed under general anesthesia. Indiana 69205. Code 69205 is also reported in cases where the foreign body is so large, an incision is made in the external meatus to enlarge the opening before the foreign body can be extracted. Removal foreign body, intranasal, office-type procedure. Requiring general anesthesia. The physician removes a foreign body from the inside of the nasal cavity, in the office for 30,300 or under general anesthesia for 30,310. Foreign bodies are defined as objects not normally found in the body. An object may be embedded in normal tissue as a result of some type of trauma. Topical vasoconstrictive agents and local anesthesia are applied to the nasal mucosa. A small incision may be necessary to access the foreign body. Blunt dissection and retrieval of the object is performed with hemostats or forceps. Sutures may close the mucosa in a single layer if the size of the dissection requires. Removal foreign body, intranasal, bilateral rhinotomy. The physician removes a foreign body from deep within the nasal cavity, accessing the area with a lateral rhinotomy surgical approach. This foreign body is located in an area of difficult access and requires complex surgery to remove it. A full-thickness skin incision is made from the nostril extending along the nasal alar rim and continuing superiorly. The incision can extend to the medial aspect of the eyebrow if necessary. The lateral aspect of the nose is retracted, exposing the bony structures beneath the soft tissue. Blunt dissection and retrieval of the object is performed with hemostats or forceps. The surgical wound is closed in layers. Exploration with removal of deep foreign body, forearm, or wrist. The physician removes a deeply implanted foreign body from the forearm or wrist. The physician incises the site and dissects down to reach the area where the foreign object is embedded. Exploration of the site is done. Separately reportable X-rays may be taken to locate the object. All parts of the object are removed. The wound is sutured in layers. Removal of foreign body, upper arm or elbow area, subcutaneous. Deep, subfascial or intramuscular. The physician removes a foreign body of the upper arm or elbow area. If the foreign body is a result of trauma, an open wound may already exist. The physician may make a separate incision or access the foreign body through the open wound. More extensive dissection in a larger incision may be necessary for a deep foreign body. Once the foreign body is visualized, it is removed. The physician may also debride any surrounding damaged soft tissue. The wound is irrigated. Drains may be placed in the wound and the incision repaired in layers with sutures, staples, and slash or stri strips. A splint may be applied to limit elbow motion. Removal foreign body, foot, subcutaneous. Deep. Complicated. Subcutaneous refers to something under the skin. An incision is made through the skin and it is reflected to expose the foreign body. It is removed and the wound is irrigated and the wound is closed. A dressing is applied and aftercare may include antibiotic injection into the wound and orally. Weight bearing is allowed as the wound heals. Removal of foreign body, pelvis, or hip, subcutaneous tissue. Deep, subfascial or intramuscular. The physician makes an incision overlying the site of the foreign body in the pelvis or hip. The foreign body is removed from the subcutaneous tissue. Indiana 27086. Deeper dissection is required. Indiana 27087, and more attention may be given to possibly damaged vessels and slash or nerves. The physician irrigates the wound. The incision is repaired with sutures, staples, and slash or stri strips. Removal foreign body, deep, thigh region or knee area. The physician removes a foreign body, i.e., nail, piece of wood, in the thigh or knee. For a foreign body in the thigh, an incision is made overlying the object. Tissue is dissected around the object. The physician may need to suture damaged muscle or other soft tissues. The wound is irrigated with antibiotic solution. The incision will typically be closed, unless an infection is present, in which case it will be left open temporarily to drain. Removal of foreign body, shoulder, subcutaneous. The physician removes a foreign body of the shoulder. The physician makes a small incision over the foreign body and reflects the skin to expose it. The foreign body is removed, the wound is irrigated, and the skin is closed with sutures or stri strips. Removal of foreign body, shoulder, deep, subfascial or intramuscular. The physician removes a foreign body from deep within the shoulder, such as an artificial shoulder joint. A long incision is made overlying the shoulder. The physician dissects through each layer of tissue down to the bones in the shoulder. The shoulder joint is exposed. The physician may debride any inflamed synovial or other scar tissues. The foreign body is removed from within the joint and from inside the humerus bone. The physician irrigates the joint with antibiotic solution. The wound is closed in layers unless there is infection present. If infection is present, the wound is left open to drain.